Another minute. We'll get started right at noontime Eastern Standard. So we'll give it about another 30 seconds. Sounds like looks like we are up and running and we are live. So I think I'll get started. It looks like it is right about noontime. So welcome to AMAT Skin Cancer's webinar series, Skin Cancer in You. I am your host, Krista Rubin, nurse practitioner and AMAT Skin Cancer's Ask a Skin Cancer Nurse. So welcome, thrilled to have you here today. And for those of you who may be joining the webinar and are not familiar with our organization, AMAT Skin Cancer is a foundation dedicated to raising awareness and providing support for those affected by skin cancer. It's my honor to help you navigate through our enlightening series designed to explore a variety of ways and topics that we can help you understand skin cancer treatment, diagnosis, management, as well as the emotional aspect of those affected. So my guest today is Dr. Govind Warrier. We're going to be discussing the neoadjuvant treatments of squamous cell carcinoma specifically. Dr. Warrier is an assistant professor, medical oncology, in the Melanoma Skin Cancer and Cancer Immunology program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in Baltimore. He specializes in caring for patients with high risk and advanced skin cancers. I'm thrilled to have you here with me today. So welcome, Dr. Warrior.
Thank you so much for that kind introduction, Krista. And yeah, my privilege to be here with you today to talk about this important topic.
Yeah, definitely an important topic. So I think what would be most helpful is to talk about historically how cutaneous squamous cell has been managed, because I think that will kind of set the stage for where it's evolving and where we're going. So if you will, could you just briefly maybe talk about the neoadjuvant, adjuvant, and perioperative therapies that are traditionally been used for squamous cell?
Sure. So just to set the stage, cutaneous squamous cell carcinoma is the second most common type of skin cancer that we see. And there's over 2 million cases of cutaneous squamous cell carcinoma diagnosed in the US every single year. And what we know is that many patients with this type of cancer present at a relatively earlier stage and can be successfully treated with just surgery alone. But what we know is that the timing and the sequence of various therapies that can be offered is really important, because that can really impact the chance of a successful outcome with the treatment, like surgery, and decrease the chance of a cancer recurring. So that's where we get into these other terms that you mentioned: neoadjuvant, adjuvant, and perioperative therapy. So neoadjuvant therapy is basically treatment that's given before the surgery to hopefully shrink a tumor or to stop the spread of a cancer. Treatment given after surgery to kill any remaining cancer cells or to reduce the risk of the cancer coming back, that's called adjuvant therapy. And when you combine those two, neoadjuvant, then the surgery, and then adjuvant, that's what makes perioperative therapy.
Yeah, and those are important concepts, because those aren't words we typically use when we're describing treatments for patients when we're in clinic with them. But now, with the evolution of these specific kind of categories of treatment, it's important to understand those terms. So I appreciate you taking the time. So
And you mentioned, sorry, I should tackle your question about what's historically been done as well that you asked. And so historically for cutaneous squamous cell carcinoma, as I mentioned, for many cases they're treated with surgery alone. There are some cases of cutaneous squamous cell carcinoma, though, that were considered to be a little bit higher risk. And historically, when we say higher risk, what we're worried about are these cancers more likely to come back? Are they likely to grow or spread into nearby areas or even metastasize to further areas? Or can they be life-threatening? And so that's where we think about leveraging additional types of treatments alongside the surgery to decrease that likelihood. And historically, to answer your question, that's been given in the adjuvant setting, things like radiation therapy after the surgery has been done.
And that can be a challenging concept for many patients and families to understand, is the adjuvant therapy, because essentially we're treating a risk of a cancer possibly still being there or coming back as we so kind of casually use those words in clinic. So the concept of really being proactive to minimize somebody's risk of relapse or risk of the cancer spreading or coming back is really crucial to patients living longer. Am I correct? And so the concepts of neoadjuvant, adjuvant in these therapies has really become central to how we manage patients nowadays.
That's absolutely right. And unfortunately, none of us has that crystal ball to
Right.
say, here's this patient that had a surgery done, and we may or may not recommend adjuvant therapy. What we know is that you're exactly right. We're treating the risk that something may come back. And something may come back because there may be something, that the surgery either didn't fully address or that was outside the scope of where the surgery was being done, meaning a cancer cell that's floating around. What we know is that some portion of patients that may be their reality. And so we give them the adjuvant therapy to hopefully take care of that. But there's another group of patients who are getting the adjuvant therapy that may not have that risk. And so we may also be overtreating some number of patients as well. But there's no perfect way to know. But we can get into neoadjuvant therapy. Maybe this is an improvement on the current paradigm.
So I'm going to bring it back to neoadjuvant therapy, and I just want to pause and just remind our audience members that if you have questions, please submit your questions through the Q&A option down on the bottom of your screen. We're happy to answer those either through the webinar or at the end. So please go ahead and submit your questions. All right, so I think what I'm going to do is narrow it into specific neoadjuvant. There's been a lot of interest lately on neoadjuvant immunotherapy. Let's talk a little bit about that specifically. Why is there so much attention, and what is it that's so exciting that we're seeing lately?
Sure. Yeah, great question. So neoadjuvant immunotherapy, I'm just going to talk about immunotherapy in cutaneous squamous cell, just a level set here. So immunotherapy itself for stages of cutaneous squamous cell where surgery is not an option has been, relatively successful. And I say that just in the context of the responses to immunotherapy that people can have in the setting of more advanced cases, where roughly about half of patients can have a really meaningful response, meaning things shrink down or potentially even go away completely. And so the idea here behind neoadjuvant immunotherapy is that perhaps activating a larger and more diverse army of those immune cells that are trying to attack the tumor, that could lead to better outcomes actually after the surgery. Put another way, the idea here is showing the immune system a bigger target while the tumor is still in place. The immune cells then after surgery may be more prepared to engage in surveillance, to respond to any remnants of the tumor that may be left behind or are trying to spread. And that's been why this has been of really high interest.
So what you're saying is that essentially it may be better in the long run to give these therapies while the tumor, the squamous cell cancer, has not yet been removed, because there may be a more vigorous response by an individual's immune system when it can learn where and what the tumor is all about. Is that fair to say?
Absolutely. The amazing thing about the immune system is the memory and the adaptability that it has. And so, if we can really train the troops, so to speak, that's the analogy I use a lot with my patients. If we can train a larger army up front that, can then be on patrol after, that's exactly the hope, is that it might be more beneficial. I should mention that there's also a couple of other potential benefits with giving the therapy up front, that neoadjuvant therapy, including the potential to reduce the scope of the surgery that's needed and potentially eradicating any cancer that may have already been in the process of spreading beyond where the surgery was intending to be performed. And finally, it also gives the opportunity to study what was the response to that particular treatment, by evaluating what happened after doing that surgery.
Yeah, it's pretty amazing. It's pretty amazing, this kind of paradigm shift that we're talking about now. And really the concept of giving treatment while the tumor is still in is actually pretty new and novel in the world of skin cancer treatments, but certainly very exciting. So I want to just talk a little bit touch upon what you said earlier. And you mentioned the word meaningful response. Can you define that a little bit more for our audience?
Sure. So I try to keep things pretty simple when I, think about when I'm talking to patients and when I think about the patient sitting in front of me.
Mhm.
It really, if we think about every single clinical trial that's out there, when we think about a meaningful outcome, we're either trying to help patients live longer and or live better. Ideally, we're doing both of those things, right? And so when I say a meaningful response, what I'm meaning is, okay, can we get a chance that we're going to really change the trajectory of how this would have gone by giving the therapy up front, by not only getting this thing to shrink down, but long-term outcomes. We're always trying to play the long game. And secondly, is that going to lead to improved quality of life for the patient that's sitting in front of me as well? So that's how I distill down what's meaningful.
And that's actually a great introduction into my next question. And it may be a little out of context now, but I think because you opened the door, I want to enter through it. And that is, let's talk a little bit about squamous cell in particular, because many or the majority of these cancers, these tumors are on the head and neck area. And they can be large, they can be painful. Certainly body image is an issue. These can be tumors that are very, what we call morbid, can be painful, uncomfortable. And so particularly with this disease, being able to really maximize the treatment effect is crucial. So could you talk a little bit about who are the best individuals to receive this therapy? And we may need to talk a little bit more about the evidence showing who benefits from these treatments first. So maybe I should flip that and ask you to just describe a little bit the data behind these decisions at this point about what treatment someone should get and when.
Sure. I'll touch on the group that was included in sort of, you mentioned the word paradigm changing. That's really what the study was. Now published a couple of years ago in the New England Journal of Medicine. There was a phase 2 clinical trial looking at giving this neoadjuvant immunotherapy, specifically this medication called cemiplimab, to patients with resectable high-risk cutaneous squamous cell carcinoma. So again, given for up to 4 doses ahead of having their surgery done. The primary outcome in this case was actually evaluating what was the level of response in the pathology specimen. And again, that's important to understand because that's, an academic endpoint that we're looking at, but we also want to be very mindful of how that translates to benefit for the patient. When we think about who was included in that study, it's very much the population that I would think about using this type of approach in now. And that is, when we say high risk, we're really talking about a few things. You mentioned that the head and neck region, it's a higher risk area, lots of blood vessels, lots of nerves, lots of lymphatic vessels, the railroad tracks for things to travel around the body. When things are larger, when the cutaneous squamous cell is larger, patients included in the study had, if they were on the earlier stage, had lesions that were at least 3 centimeters in size or larger. Was there nerve involvement and some adverse sort of features on the way that the cancer was growing as well? Those are the patients that I think about this in.
And I'm going to apologize now. We seem to have some landscaping going on outside of my environment right now. That we have lots of leaves in the Boston area, and those are being blown away. So I forgive any background noise that you may hear from me. So I think one of the things that would be most helpful, just from what I hear in my clinic and the questions that I get from patients, is how do you decide who gets what and when, and what makes my cancer unique or specific? So maybe you could talk a little bit about, or walk me through a clinic visit with somebody who's coming in with a large squamous cell tumor on their head or neck area and has not yet seen any treatment, not had any therapy. Could you just kind of walk through what the discussion would be like very briefly?
Yeah, great question. And this comes up, now nearly every single week for me. So, the first and foremost is, I think, with these sort of new approaches and new therapies that are coming out, we always have to personalize it to the person sitting in front of us. And just because there is a new type of evidence out doesn't mean it's always right for the person sitting in front of you. And certainly it's a shared decision that you make together, weighing the risks and benefits of each of these approaches with the individual patient in question. But certainly someone who had any of those high risk features that I mentioned to you, and they are otherwise, there's no other medical condition that may be limiting us from using immunotherapy, perhaps an underlying autoimmune condition, perhaps they're on medications that might suppress the immune system, which wouldn't really give the immunotherapy a chance, or I would worry about how they'd be able to tolerate side effects from the immunotherapy. All of these kind of things weigh in, along with, certainly the risks and benefits as the patient perceives them as well, because certainly these therapies are not without their potential risks.
So is this a time to talk about that now, or should we, you open the door again? So we'll walk through that again. Let's talk about what's it like. So there's a decision to move ahead with neoadjuvant immunotherapy. What are those options, medication-wise, specifics? And then how many doses, that type of thing. And then perhaps we could talk a little bit about tolerance.
Sure. So, as I alluded to in the study, patients were with high-risk cutaneous squamous cell carcinoma were given up to 4 doses neoadjuvantly of this immunotherapy called cemiplimab. So this is not to get too technical, but for I know some in the audience may be familiar and have done a lot of their own research. This falls into this category of medications called anti-PD-1, which is trying to block a particular checkpoint that immune cells have, and so trying to really ramp up the immune system by that mechanism. So patients received up to 4 doses, and then they went to surgery, and then they evaluated in how many of these cases was there a really good response. And it turns out to be the case that in just over half of the cases, there was actually no cancer left over in that particular specimen. Now, you asked about the risks as well, and the risks, as we've learned more and more about these types of therapies, the risks in the study were pretty similar to what we see when we use these across a variety of cancer types. And that is, there is this sort of 10 to 15% risk of having a higher or more a grade or more serious reaction to the immune therapy. And specifically, that manifests as inflammation. And the way I describe that is, as the immunotherapy is trying to go after the cancer, normal, healthy parts of the tissue can get hit in the crossfire of the immune system getting revved up. And that can manifest as inflammation of really any sort of organ. So we do a lot of counseling, in terms of those potential side effects. And I would say over communication about, is the right amount of communication as you start one of these therapies.
Yeah, there is no such thing as over communication when it comes to managing
Right.
side effects or identifying side effects of immune therapy. I want to go back to something that you mentioned a bit ago, and I want to just clarify or talk a little bit more in depth about, you mentioned the specimen. They look at the specimen. So surgery involves removing the tumor itself, if it's still present, as well as the lymph nodes that we know, or there has been a biopsy showing that the squamous cell has spread to those lymph nodes. So the surgery involves removing those lymph nodes. Describe for our audience what is looked at. How do they determine whether or not there's been a response?
Great question. So this itself is sort of an active area of evolution, because there were not until too long ago established metrics for how do you even assess the response that you see under a microscope, especially with immunotherapy, which works very differently than every other type of therapy that's out there. So essentially, what they're doing from a high level is they are looking at on the specimen, what was the bed that the original tumor, was in, and you can look for features that suggest that the immune system really fought back the tumor, and you can sort of see evidence of regression of the tumor. So when I say, 50, it was 51% to be precise,
Impressive.
was the quote unquote complete response, pathologic response. What that means is 51% of the specimens, there was no tumor seen in the bed that the tumor originally was in. And I should note that there's this other term that some may see called major pathologic response, and that's sort of this, where there was a really meaningful response, but there's a little bit of tumor left over, less than 10%, somewhere between 1% to 10% or so. And another portion of patients had that finding as well. So the majority had a really favorable outcome, at least from the pathology side, with this therapy up front.
Which is actually really incredible because we don't see numbers like this generally in oncology. So to say that over half of the patients that had their lymph nodes removed, there was no evidence of the cancer after just a couple of doses of immunotherapy is really quite profound. And that's why there's been so much excitement about the neoadjuvant approach to using immunotherapy with squamous cell. For those folks that had this major response, could you just clarify what went on to happen to them? Was there any lesser response in the long term compared to somebody who had a complete response?
Yeah, excellent question. So this is why we think neoadjuvant therapy holds so much promise, because what we know is that if we see evidence on that from that surgery specimen that there was that complete response, this has historically corresponded with really good clinical outcomes. And clinical outcomes, at the end of the day, are what we're after. Like I said, we want patients to live longer, live without their cancer, and to live better, with or without their cancer as well. So here's the important bit: there was a 2-year follow-up from the study just presented at a big conference in Europe a few months ago, and among the 70 patients who underwent surgery in the study, it's important to understand that they could have received a few different therapies in the adjuvant setting, and that was up to the person that was treating them. But I'm going to talk about those patients that I mentioned that had a pathologic complete response. There were 40 of those patients out of that 70, and none of them had experienced any recurrence to date. And additionally, in the group of 10 that had that major pathologic response, only one person has experienced a recurrence. So really supporting that hypothesis that getting a good response up front really leads to good long-term outcomes.
That's incredible. It really is very incredible. All right, so we have the medical oncologist, you as a medical oncologist, you have the surgeon, and you have the pathologist. So this kind of talks about the importance or highlights the importance of multidisciplinary involvement in this patient population. We actually had a webinar, one of our first webinars talked about the importance of multidisciplinary care. And I think here is a great example of that importance. So how does it work at your institution with regard to your I presume it's a multidisciplinary practice. So how do you kind of all meet and talk and work through this patient population that you see?
Sure. So at our institution at Johns Hopkins in particular, we're very fortunate to have a close-knit multidisciplinary skin cancer group. And so we talk about many of these cases, as early as possible. And I think that's really the goal is, anyone with these high-risk squamous cell carcinomas, you really need all hands on deck up front, because not only are there a lot of nuances to mapping out, and discussing with the patient the risks and benefits of each of these, portions of the treatment, but you also want to, make sure that you're allowing the time for the logistical elements of if you are going to do the medical therapy up front, timing that with surgery and all of those things as well. A lot tougher to do once the ball is already rolling on one front or another.
Yeah, and it is from kind of the start of meeting a patient to the time that they get therapy. Cemiplimab is given once every 3 weeks, a few doses. So you're looking at a couple of months possibly before somebody kind of walks through the door, starts their treatment, and then goes to surgery.
Yep.
So let's talk a little bit about what happens after. So after surgery, somebody has a complete pathologic response. What do you recommend?
Yeah, this is a great question. And there's some ongoing research in the space. Like I said, in this study, it was left a bit open-ended actually to the treating physicians of how they wanted to, pursue additional treatment. And I'm sure they made that decision, with the patients as well. But things that could be considered: one, just observation, actually. So the 4 doses of therapy, if they have a complete response, certainly not unreasonable to just watch those patients. And as we get longer follow-up data suggesting that they're, very unlikely to experience a recurrence, that's really encouraging. And it's good to be able to tell patients that, radiation still remains certainly something to discuss. That's been the historical standard approach, as I mentioned to you, and certainly not wrong to consider. The one piece of evidence that's we're still waiting on some additional data for is what's the role of additional medical therapy after giving the neoadjuvant therapy. So there are a couple of clinical trials going on in that space, but we're all very eagerly anticipating the readout from those. But no definite consensus there yet.
All right. So again, for our audience, please submit any questions that you have to Dr. Warrior. Happy to answer those. And we often get great questions from our audience. So while I'm waiting for some more of those to come in, could you perhaps talk a little bit about the type of imaging that patients could expect to have done? So in order to generally biopsy diagnoses the spread to lymph nodes or surrounding tissue, what other types of diagnostic testing is generally done or can somebody expect?
Sure. I think there are a couple of different types of scans that may have a role. So CT scans are often very commonly used. In our practice, I would say that, and guidelines would support this as well, we usually end up doing, if this is a head and neck case, which many of them are, we'd get some imaging of the head and the neck. We certainly want to evaluate for the lymph nodes in that area. We'll often get imaging of the chest as well, because the lungs are one of the places where we don't want to miss, any early evidence of metastases, and they can be one of the early spots where these head and neck cancers can spread to. So we'll usually do that. There may be cases where because of the specifics of where the lesion is, an MRI could be helpful. And an MRI can also help tease out if there's involvement of nerves a little bit better than the CT scan
Mhm.
is as well. And on occasion, the surgeons may ask for the MRI specifically because it helps them in their planning of their operations.
Which is another reason about, to highlight the importance of multidisciplinary care, really talking about what is the best type of what type of imaging is best for an individual, because that does vary person to person. Okay, and then, so hypothetically, somebody has, their 2 or 4 doses of cemiplimab, they have surgery, they have a great pathologic response. You talk about going into a period of observation. Now, that doesn't mean that we just say, see you later, and, call us if you need us. Could you talk a little bit about what a course of observation is?
Sure. And perhaps we should use the term active
I
surveillance, right?
think that, yeah, that's
That's
what we've been thinking
yeah,
about
yeah.
going to.
Yeah, yeah. So I like that as well because it really is. We're not just sitting there as you
It's an
said.
active follow-up as
That's right.
opposed to
That's
a
right.
passive follow-up. Yeah.
That's right. And I think we certainly ask a lot of our patients, but we ask a lot of ourselves to make sure that we're staying on top of
Mhm.
keeping this thing back. And so this again, I think is the importance of multidisciplinary care. So from our perspective in medical oncology, we may see these patients a few times a year, but we just want to be on the lookout for any early signs of recurrence. We may often be coordinating the completion of serial scans, and we do a dermatologic exam as part of our evaluation as well,
Right.
but certainly not a substitute for staying very closely plugged in with the dermatology team. So perhaps every 3 to 6 months, you should be seeing your dermatologist and making sure we're catching any signs of not only that cancer, but if you've developed that one, you're at a higher risk for others.
Right.
Staying on top of those things. And then, of course, follow up with the surgeon to evaluate the local site where the surgery was done will be very critical as well. So, again, very multidisciplinary process for the follow up.
And I presume that your practice is similar to ours and that, we don't want people coming in having to have multiple appointments multiple times. We try to, be thoughtful about, okay, well, perhaps if you're seeing the surgeon this time, maybe you could see the medical oncologist next time. And then I'll put in a plug too, of course, because one of my areas of focus is the management of immune-related adverse events. So after somebody has received these therapies, of course, we're still monitoring for late effects, which are rare, but if you've had immunotherapy, you can have delayed effects even up to 1 or 2 years later. So one thing that I know a lot of the advanced practice providers do, in addition to the physicians, is really focusing on directed questions, trying to get a sense of, is there anything that may be suggestive of an adverse effect?
Yeah, both excellent points and certainly always on our radar. You make an excellent point about, these side effects from the immunotherapy, again, are very different than other medications where they can come on even, some even years into a treatment course, even if you haven't received any of the medication, recently. So
Mhm.
certainly something we always ask about as well.
And as we end, if we get near to this webinar, I just want to highlight one more thing and ask you a question about this, and that has to do with age. So many of the patients that have advanced squamous cell carcinoma are in their, seventh, eighth, or ninth decade of life. And what has really been pretty profound to me is that we can still treat these individuals. There are high risks of the disease itself, high risk folks for anesthesia, perhaps surgery could be questionable, but this is a population that we still are able to treat where historically we may not have been able to offer some of these therapies to somebody in their eighth or ninth decade of life. Could you just briefly talk about perhaps the ages in the trials and the ages in the practice that you have?
I think that's a excellent point that you're bringing up. So the median age of someone with these high risk cutaneous squamous cell carcinomas is generally higher, 70s, that sort of time for compared to someone with say melanoma or other types of skin cancer. And that has implications on many fronts. You alluded to a
Mhm.
couple of very important ones. Of course, they're how feasible a surgery is, the risks and the benefits of the surgery itself. And from our perspective, I mentioned this early on, sort of when I'm discussing with a patient, I'm thinking about not only what are the theoretical risks of side effects if they were to pop up with immunotherapy,
Right.
but the
Yeah.
practical aspect of how would we manage this if one were to come up. And
Mhm.
just by nature of once you're older, there are more issues that you're probably having to juggle. Then managing some of those side effects may become a bit more challenging. Now, I take an optimistic view of we want to give everyone a fair shot. And just like you said, we're not dealing with chemotherapy or other types of therapy here. And immunotherapy really can be well tolerated. I've treated patients as old as a little slightly over 100. They've done quite well. So we want to give everyone a fair shot, but just want to do it as thoughtfully and safely as possible.
Yeah, that's well said. Well said. Well, we're at the end of our half hour, and I want to say thank you very, very much to Dr. Warrior for joining us. This is really an exciting area of interest, and I think this is just the beginning. And hopefully, this is something that we will be seeing more and more of, less and less of treatment, less immunotherapy, less surgery is really the goal, and helping patients to live their best lives is our goal. So I thank you to the audience who has joined us today. These webinars are designed to be informative and helpful as you journey through your cancer course. So again, thank you, Dr. Warrior. Please join us for our next webinar, The Genetics of Skin Cancer, taking place on January 22nd. And I will be joined by Dr. Kenneth Tsai. So hopefully you can join us then. I wish everyone a happy holiday season. And again, thank you, Dr. Warrior.